Hi, this is Terry Kuti, and I am doing another video here in Chicago at Plastic Surgery The Meeting with Dr. Minas Chrysopoulo from PRMA in San Antonio. So Dr. C, when I had my DIEP flap in 2014, I was in hospital for 5 days. I was on narcotics. I felt a little foggy-headed. I felt like I was sleeping a lot because I had this what do you call it? The
PCA?
Yes,
The
thank
button.
you. I had the button. Start feeling a little pain, hit the button. Out I'd go. I had a catheter in for 5 days, and I got to tell you, that was my least favorite part.
Was it in for 5 days, really?
Yeah,
Wow.
it was.
Yeah, that's long.
Didn't like it.
I wouldn't either.
And another really icky thing, I didn't have solid food, I think it was my second day maybe. I got really tired of broth.
Did you have nausea? Was that?
No, I didn't.
Okay.
I didn't. That was well controlled for me.
Doesn't sound like much fun.
Well, it was, I mean, I had such a successful DIEP. So let's just put that out there. But, you know, I always tell women that recovery was not a cakewalk, but you get through it. The hardest part for me, I think, was laying in bed that many hours a day. That's what I didn't like about it. And I thought if they bring me one more cup of broth, I was going to throw it on their face. I was so happy to get my first plate.
I've tasted it. It's nasty.
But now you have something new in place. Well, it's not really new, but I got to see it, new-ish. I got to see it firsthand in April. I was doing some advocacy work, and I saw some of your patients. I walked down the hall to greet them, and I'm like, okay, you just had surgery yesterday. You don't have your catheter in, and you're up walking around like I was, like on day 3 or 4. Tell us about it.
So
I was so glad. I've heard about it, but I was so glad I got to see it in action.
It's a great protocol, the ERAS protocol, Enhanced Recovery After Surgery. That's what ERAS stands for.
Yeah.
So it's been described for many procedures, actually, not just breast reconstruction, but it has been described also specifically for microsurgical breast reconstruction, like the DIEP flap. And it's wonderful. It's been a game changer.
I saw that.
Yeah, no, it's really it's great. So it's basically a protocol that starts before your surgery.
Okay.
And it optimizes nutrition. It optimizes your pain control during and after surgery. Really speeds up the recovery process in many ways. And it avoids a lot of the narcotics that we used to be dependent on. So now, instead of having narcotics scheduled as your main method of pain control, it's only used if the other stuff you're taking for pain isn't working, if you need an extra little bit of help, right? So the process starts before surgery with a carbohydrate drink.
I was just going to ask you to give the specifics.
Yeah, so
Carbohydrate
it used
drink.
to be, we used to tell people, oh, nothing to eat or drink after midnight.
Right.
So now we know that if you give a heavy carbohydrate-laden drink, then it prepares the body for surgery a lot better, and you avoid the delayed onset of your GI system, your intestines working after surgery. They start working a lot quicker. Also, we limit the amount of fluid that we give during the surgery through the IV.
Oh, okay.
So you don't swell as much, because we know now that swelling isn't just what you can see externally. It's not just your arms and legs and whatever that get a little bit puffy like they used to, but also your everything swells. So even your intestines swell.
Yeah, it's not putting pressure on all that added fluid, not putting pressure internally.
Right.
Okay.
And then what happens is that that swelling slows down the return of everything working. So your intestines are slower to come around. So we used to really take our time and moving you to a full diet. And anyway, now we know that you don't need to do that. So this carbohydrate-laden drink ahead of time really helps with that, along with cutting down the fluid. So instead of really overhydrating patients like we used to a while back, now we just give patients the amount of fluid that they need, rather than overdoing it. Surgeons, used to think that a lot of fluid was better. Now we know that actually the fluid that the patient needs is what they should be getting, not overhydrating them, because overhydrating them just makes them swell and slows down the return of normal bodily functions. So
does that have anything to do, not to interrupt, but does that have anything to do with having the catheter out earlier, or no? No. Okay. It's just the internal pressure of the fluid. And
so that carbohydrate drink ahead of time sets the stage.
Yep.
The fluid, cutting back on the fluid during surgery sets the stage, and then afterwards, in terms of fluid, we would keep. I don't know if you remember, but you were on IV fluids for days.
Yes.
When you did it.
Yes.
Now we cut them down. We cut them back very, very quickly.
Yep.
So, and to the point where you're on a regular diet as soon as you can tolerate it. It's not this prolonged process anymore.
Yes, and that's what I noticed when I saw them coming down the hall.
Yeah.
I had multiple bags hanging off of my pole, and I looked, I'm like, they hardly had anything.
Yeah. So the other thing we do with the ERAS protocol that we didn't do when you were there, I think when you were there, we were still doing the pain ball, weren't we? We had a little.
I had that for my mastectomy prior to 7 months prior to you, but no, I didn't.
So
I didn't have that.
Yeah. So now we're doing blocks on the inside.
Yes.
They're called tap blocks. And that's basically
intraoperatively.
Exactly. So that basically allows us to inject long-acting anesthetic right over the nerves that supply this area, the lower tummy, and so that adds a level of pain control that patients didn't have before. That decreases the amount of pain medicine they need to take orally. The oral pain regimen is completely different. We use Celebrex, which is a non-steroidal drug, kind of like ibuprofen.
Okay.
We also use extra strength Tylenol.
Okay.
And we use gabapentin, low dose.
Yeah.
So those three things are scheduled around the clock, and in our practice we do that for 2 weeks.
Okay.
And then you also have narcotics available in case you need them.
Yes.
For breakthrough pain.
Okay.
So those drugs on their own that I mentioned, they're not particularly, big hitters, but the combination works phenomenally well.
Okay.
And so when you take out the narcotics from the equation, patients don't feel foggy anymore. They don't feel sleepy. The PCA, the button you mentioned,
yes.
We haven't done that in years. Right. So a very rare event, someone will have very, very high requirements.
Yes.
So I'm not going to say it never happens, but it's exceptionally rare these days for us to put a PCA give a patient a PCA.
Yeah.
So patients don't have the constipation that they would get, after surgery from the narcotics. And that together with, and they don't have the nausea either that narcotics can give you. So all those things together means that the patient is able to start eating quicker, they're more with it, so they can get up and walk quicker. We take out the Foley catheter very quickly too. They're not getting overhydrated, so they don't need the catheter like they used to.
Right.
All that enables earlier mobilization, so they can get up and walk sooner and do more the first couple of days. And now our length of stay has come down. Yours was 5. That was also at a time when our out-of-state folks were staying an extra day.
I was out of state, yeah.
Now whether you're out of state or local, I tell my patients you stay 2 days. So length of stay is now down to 2 days. That's the goal. Sometimes it ends up being 3, but the goal is 2 days. Because anyone who is ready to go medically at 2 days is going to have a much shorter recovery overall. So ERAS has been a game changer.
Oh yeah, and like I said, seeing it firsthand, it was a visual game changer for me too, just to be able to see those women
Yeah.
a few days before.
Yeah, it's a great protocol.
I'm really glad we talked about this. I like to tell other women, and this actually happened. I've told other women, ask your doctor. Not everybody's practicing ERAS, we know that. But there was a doctor who I guess hadn't heard of it. I shared it with the woman, she shared it with her doctor. They put it into practice.
Patient advocacy for
Yeah.
you. That's the change right there.
Teamwork is
Patients
what I
drive
like
change.
to. Yeah. Hey, thank you so much.
You're welcome.
This is a good informative video. Thank you.